Well, I'm Rani Singh, those of you who do not know me. I welcome you to our HRSA-funded SERC Lunch and Learn series. And I also want to welcome all the people who have tuned in from 8 or 9 other sites to listen to a very important topic here. MPS1, we'll be talking about that. As you all probably know, with the Secretary's Advisory Committee, this is one of the disorders which has been recommended to be added to the RUST panel for the newborn screening, even though there's no funding being given by the federal government for these activities. At this point, it has been nominated as one of the conditions, along with the ALD, to be considered by the states to be expanded. So just as a reminder, again, the process for adding condition has been adapted and modified by the Secretary's Committee now, and it goes through a thorough systematic evidence review, which was presented to the Advisory Committee by Dr. Alex Camper from Duke. In addition to that, after that, the committee evaluates the boundaries of the benefits and harms, so the certainty of benefit is very critical for the disorders which are being added to the newborn screening panel. And finally, the other component which they are looking at is the readiness for the labs, that if the tests are there, and how practical they are from the comprehensive newborn screening system to be implemented later on once the states do embrace them or include them in their expanded panel. So given that background, and this is our 4th year of the 3rd cycle of the HRSA grant, for which I serve as the PI for the Southeast Regional Collaborative. We have 1 more year, and we will be continuing the series. And we are planning to put in an application for the next cycle, which is in plans by HRSA. So having given you that background, I'm going to go ahead and introduce our speaker. We are very, very honored to have Stephanie Cagle, a genetic counselor who's a colleague here. She received her master's in genetic counseling in 2009 from Mount Sinai School of Medicine. Then she began working at Emory here in the summer of 2009, actually, and joined the LSD team. And in 2010, she started her new role, or the primary role, as a care coordination for patients with MPS. So she was thinking ahead. She currently follows about 40 MPS patients and very much enjoys working with these patients and their families. She's also a study coordinator for several sponsored clinical research trials. And I know Stephanie will contribute both locally, regionally, and nationally with her experience as we forge forward to add this disease. So I welcome, please join me in welcoming Stephanie.
Thank you, Ronnie, for the nice introduction, and thanks to SERC for inviting me to be a speaker today. So I'm going to talk about mucopolysaccharidosis type 1, which Ronnie just gave a nice introduction, mentioned that it is up for being added to the newborn screening or to the RUSP. So I'm going to go through the different phenotypes of MPS 1 and then talk about some considerations for newborn screening. Okay, so what is mucopolysaccharidosis type 1? This is a lysosomal storage disorder that's caused by the deficiency of the enzyme alpha-L-iduronidase. So it's a lysosomal enzyme. It is required for the proper degradation of glycosaminoglycans. So the 2 GAGs, if you will, that alpha-L-iduronidase is responsible for helping to break down are dermatan and heparin sulfate. So what happens is if there is absent or deficient enzyme, then the breakdown cannot occur as it should occur, and then that material, the dermatan heparin sulfate, becomes stored in the lysosomes of the cell. They become engorged. Eventually the cell dysfunctions, then the tissue, and then organ dysfunctions, and then you get the symptoms of MPS type 1. So here are some of the symptoms that these patients can experience. They can have recurrent ear infections, recurrent respiratory infections, They can have obstructive sleep apnea due to enlarged tonsils and adenoids, or the restricted airway that they get from the storage in their respiratory system. They can have cardiovascular disease, particularly cardiac valve dysplasia and dysfunction, carpal tunnel syndrome, both umbilical and inguinal hernias. They have a lot of skeletal deformities, so that can be quite a large burden on the patients. It's getting their skeletal complications cared for. And I'll talk a little bit more about that. Here we have some examples of some of the symptoms. You can see this girl has a umbilical hernia. And then this child both has hepatosplenomegaly, which can be seen in MPS1, and also has a gibbous deformity of his spine. Most of these patients have joint contractures as well, in all of their major joints, but in the fingers as well. You can see how this child's hand is. He can't extend his fingers fully. It just stays like that. Okay, an example of corneal clouding that can happen in these patients, and another example of the hepatosplenomegaly. And just to also point out, patients with the more severe phenotype have coarse facial features, which you can appreciate in this child here. Okay, so before I get into kind of drilling down some more about the phenotypes, a little bit more about MPS type 1. The incidence is estimated to be about 1 in every 1,000 births. Seems to, it's pan-ethnic across all groups. Both males and females are affected. It is an autosomal recessive condition, so both mom and dad need to be a carrier in order to have an affected child. It is a condition in which symptoms can really vary greatly from patient to patient. Historically, MPS 1 has been divided into 3 subtypes: Hurler, Hurler-Scheie, and Scheie syndromes, just named after the people who first described the condition. And I'll go into those more. In recent years, there has been a movement toward towards dividing the phenotype into severe versus attenuated. A name that makes more sense for the symptoms that are presenting, and it's not just someone's last name. All right, so the subtype is usually determined by a physician, so this can be a pretty subjective call. Normally, it's done by a geneticist. Sometimes other specialties may make that call as well, but it's based on clinical symptoms, and sometimes on mutation analysis if they get that done. Okay, so Hurler syndrome, the most severe type of MPS 1. This is also called severe MPS 1. These children have cognitive involvement, so they develop normally for the first year or 2 of life, achieve their milestones fine, and then suddenly start to plateau and then eventually regress in all of their skills. So they'll eventually lose their ability to walk, talk. They have severe systemic symptoms. Again, coarse facial features like you see in this child, which are classic in Hurler syndrome. They have the corneal clouding. They have such skeletal complications that they are of a dwarfed size. So eventually, this regression just continues as the storage continues to build up. And if untreated, the survival is usually less than 10 years of age for these patients. Okay, so then for Hurler-Scheie and Scheie syndromes, this is also known as attenuated MPS 1. So these are the patients who do not have cognitive decline in early childhood. We have seen in our population that many of our patients do have some concentration issues in school. They might need some extra time taking tests, things like that, but certainly not the frank regression that is seen in the severe children. So within Hurler, Scheie, and Scheie, it can be very severe or mild as far as the systemic symptoms. So some of these patients may also be of a dwarf size, have very severe skeletal complications, the corneal clouding, enlarged liver or spleen. So they can have quite a large burden of symptoms, but they just don't have that cognitive regression in early childhood. So here, these are some of our patients that we follow at Emory. We have sisters with Hurler-Scheie, and then we have a 40-year-old with Scheie, the mildest phenotype. And again, this is just a clinical call as far as, saying is it Hurler-Scheie or is it Scheie, completely up to the physician. No real clear break between those two. So again, I think that's why it's moving toward just describing this condition as severe versus attenuated. For the lifespan for these folks, it can be limited to adolescence if they do have really severe systemic symptoms, but they can also have a normal lifespan. So in seeing these patients, it's really difficult to predict what kind of outcome they'll have. For diagnosing this condition, this is a Emory lab requisition. It might be out of date now, but it still has the MPS testing on it. So you've got someone in clinic, there's a clinical suspicion of MPS type 1. You can order urine for quantitative and qualitative GAG analysis. So I mentioned before that the GAGs that are stored in MPS type 1 are called dermatan and heparin sulfate. So in a person who does not have MPS type 1, if you tested their urine, you would find GAGs there, but not dermatan and heparin sulfate. So that's where both quantitative, how many GAGs are, or what's the level of GAGs in the urine, and then qualitative is very important as well. What types of GAGs are you seeing? So for a patient with MPS 1, you would expect the GAGs to be elevated, and then on the qualitative analysis, you would expect to see dermatan and heparin sulfate. So you can also order enzyme activity in leukocytes to see if they have an enzyme deficiency, if it's absent or greatly reduced, and then also gene sequencing. And I'll talk a little bit more about what these tests kind of can and can't tell us as well. Okay. So this is just an example of testing that we did for one of our patients. He does have Hurler syndrome, the most severe phenotype. So just an example of the lysosomal enzyme screening panel. You can see that the activity for alpha-L iduronidase is 0.1, consistent with an MPS 1 diagnosis. His urinary GAGs, the normal range here goes up to 202, and his GAGs are at 712. So pretty large elevation. And then you can see qualitatively, they note the heparin and dermatan sulfate that's present. Oh, and he did have gene sequencing, has 2 confirmed pathogenic variants, both nonsense mutations, again fitting with the Hurler phenotype. And these 2 mutations that are listed here are actually the 2 most common severe Hurler mutations that we see in patients. I think at least 50% of patients have either one or both of these mutations. Okay, so I wanted to mention alpha-L iduronidase pseudodeficiency. So this is when an individual is found to have deficient enzyme activity into the affected range, but does not actually have MPS type 1. So this can be very confusing. It's something that's been teased out a lot more as states are starting newborn screening because they're finding a lot of these patients. So essentially, they don't have symptoms of MPS. If you look at their urine GAGs, it's normal. The qualitative analysis is normal. Again, very little historical published information, just kind of learning about this now. The problem is that the assay uses an artificial substrate, the 4-mu substrate. So when you test a blood sample from a patient to try to get the enzyme activity, the functional enzyme should cleave the substrate, a fluorescence is given off, and then the level of fluorescence gives you your level of enzyme activity. So for whatever reason, the alleles that we've seen in these patients with pseudodeficiency they don't seem to be cleaving this artificial substrate. So it's looking like no activity or very little activity, when in fact, if you used a natural substrate, they would have activity in the normal range. So that's a little caveat that turns out it's a lot more common than we thought. It seems to be very prevalent among African Americans. one thing that we need is a good paper published about these different alleles. That's lacking right now. So all of the labs out there know that this exists, and we have seen some of these patients, and we all talk about it. But there hasn't been a good publication yet, like a peer-reviewed paper. So if a lab is reporting out these pseudo-deficiency alleles, there's no reference for them to go to. So that's a bit of an issue that I think will need to be resolved for newborn screening in particular. All right. All right, so for treatment for MPS type 1, so there's hematopoietic stem cell transplant. This is done with bone marrow, umbilical cord, peripheral blood from an unaffected donor. In recent years, they've even said that the unaffected donor should be a non-carrier for the best result. Essentially what you're doing is before you give the donor cells, you're ablating the immune system of the recipient, giving chemo drugs and things like that so that their body will accept the donor cells and engraft, and then they will produce their own enzyme. So, and that will, if it's successful, then that's good for the rest of their lives. If you test their enzyme 10 years down the road, it should be a normal enzyme level. So it may stabilize the cognitive impairment. It does vary a lot from patient to patient, what kind of outcome you get. So it's hard to counsel families about exactly what to expect, because every patient is different, and it depends on a lot of things. In general, it does reduce the hepatosplenomegaly. It takes the urinary GAG level, if not completely back to normal, closer to normal than it was. Helps with the lung function and the cardiomyopathy. However, the skeletal complications and the corneal clouding are still there. The bones and the eyes are not very well vascularized, so there's just not the blood flow there needed to really prevent these skeletal and corneal clouding symptoms. This is standard of care for patients with severe MPS1, ideally done before they're 2.5 years of age. You want to catch them as early as possible. So any regression that has happened cannot be undone. So when you're doing this stem cell transplant, you really want to do it as early as possible to try to preserve as much function as possible. And there are some studies, I'll talk about enzyme replacement therapy next, but there are some studies right now that are combining these two treatments, transplant and the enzyme replacement therapy, and suggesting that if you use them together, that they could provide the best outcome. So for enzyme replacement therapy, So other things to consider with a stem cell transplant, it's not a benign procedure. There are a lot of complications that can happen. Patients have to spend several weeks in the hospital. Again, they have to be given toxic medications to ablate their immune system. They have all these risks. They could get graft versus host disease if their body is fighting the donor cells. Nausea, vomiting, diarrhea, mouth sores can all occur. Definitely a big lifestyle change for the family. You have a child who's now in the hospital for months getting this transplant. So just things to consider there. Access to transplant is something to consider. There are 2 centers, Minnesota and Duke, that have done the most transplants in MPS 1 patients, so they have the most experience. So considering where you go is a factor as well. So a family could end up out of state for several months, or mom could go with the child for several months. So it's definitely a lot. But the mortality has historically been quoted around 10%, which is not an insignificant number. It is likely now less than 10% because the protocols for transplant have been modified in recent years. A lot of stuff published by Duke in Minnesota about that, which has improved survival and has improved outcomes. So overall, for the cases of severe MPS1, where the children have that cognitive regression, the benefits of transplant are considered to outweigh the risks of the procedure. So that is standard of care for these patients. So for enzyme replacement therapy, this was FDA approved in 2003, made by Genzyme. So it's called aldurazyme or leronidase. Essentially what they've done is they have made an enzyme, they create an enzyme in their production facility that you can then infuse. It's every single week. It's a 4-hour infusion, intravenous, and it's for the rest of their lives. So again, it's pretty involved treatment, time commitment, children missing school, parents missing work. When we first start children on enzyme replacement therapy, we keep them in the clinic because some patients do have reactions. So their bodies aren't making this enzyme, and now you're giving it to them, and then they can have reactions to it. Typically what we see is mild headaches, fever, nausea, things like that we can control very well. But we want them to be here with us, ideally for the first 6 months, without any reactions before we let them go to home infusion. So for this treatment, it does improve endurance, reduces fatigue, reduces liver and spleen size, urinary gags are decreased, improves joint mobility. It does seem to help stabilize the cardiac valve symptoms. Given that this is an intravenous treatment, it's not expected to cross the blood-brain barrier. The enzyme is too large to cross the blood-brain barrier. So it does not treat the CNS symptoms. Again, similar to transplant, ERT does not prevent the corneal clouding or the skeletal manifestations, so patients still have to address those separately from treatment. So this is standard of care for attenuated MPS1. So with these treatments, we are getting a new natural history of MPS1. There's a lot to learn still about how these new treatments are affecting the natural history of this condition. Transplant really started in the early 80s. Back then, mortality rate was higher, as I mentioned before. It's gotten a lot better now. But there has been an issue where many adults who would now be in their 30s have been lost to follow-up because they were discharged from the BMT service, and then they end up not following up with anyone in genetics, or maybe don't see any other specialties. I recently had a patient with Hurler syndrome who is 31, and she was transplanted at the age of 3 back in 1982. She's one of the first ones to be transplanted, had been completely lost to follow-up. She's starting to have some psychiatric concerns, so her parents contacted us and brought her in for an appointment. And she definitely is delayed, but they say that she's been stable cognitively. And you can have a conversation with her. She probably functions on the level of about a 4-year-old. As I mentioned before, she was transplanted when she was over the age of 3, so that's on the late side for what we do now. But overall, she is doing really remarkably well. And I'm sure there's many patients out there who are in a similar situation. We just haven't collected that data on them. A lot of the published data about outcomes for transplant, it's usually the data averages about 10 years post-transplant, so not really capturing much beyond that. And just from looking at this data, they have seen that the age at transplant, your cognitive function at transplant, and also your enzyme expression that you have post-transplant all really factor into what kind of outcome that child's going to have. For the enzyme expression post-transplant, that doesn't seem to be a good predictor for their cognitive course, but it does seem to be a good predictor for the systemic symptoms. So with the enzyme expression post-transplant, if they or at least making some enzyme, then that's usually enough to kind of protect them cognitively. So for enzyme replacement therapy, approved in 2003, so we have a little over 10 years of data on that now, really kind of observing the first generation of patients with attenuated MPS1 on this treatment, learning now what new issues could arise for them now that they are surviving longer. And I just threw in the psychiatric. In addition to this earlier patient I mentioned, other centers I've spoken with have reported that in a lot of their adults with attenuated MPS1, they are seeing things like depression and anxiety. It's hard to say if that's because of the MPS1, if it's because of the disease process itself, or if it's because they do have a lot of health complications, mostly live at home, still in the care of their parents or someone else. Still teasing out what the long-term effects of enzyme replacement therapy will be. These patients need a lot of supportive care, even with treatment. They need therapies, physical, occupational, speech therapies, leg braces, joint replacements. Patients are now getting hip replacements, knee replacements, hearing aids, adenotonsillectomy. If they continue to have sleep apnea, they could require CPAP or BiPAP, or at least supplemental oxygen at night. Patients with really bad airways often end up with a tracheostomy. Because of their skeletal disease burden, most of our patients have had spinal cord decompressions. Many have instability in their cervical spine and require fusion. Many have a shunt for hydrocephalus, and they can have hernia repair. Corneal transplant actually works very well for the corneal clouding, so that's been very successful. A number of our patients have had that done, and the cornea has stayed clear. We're now 15 years after their corneal transplant. They can need a cardiac valve replacement. Their valves are bad enough. We have one adult who's attenuated. In fact, she was in the picture with her sister earlier, who was needing replacement of both her mitral and aortic valves. They need aggressive treatment of infections. These kids are very susceptible, especially the severe kids. If they get a cold, it could turn into something like pneumonia for them. They could end up in the hospital. So we always recommend that the pediatrician or the ENT, whoever's addressing this, that they maybe go ahead and start those antibiotics, whereas with another child, they might wait. Wanted to mention quickly, so in addition to the standard of care treatments I just talked about, there's a couple things that kind of coming down the pipe. So there are studies about intrathecal hyaluronidase. So this is giving the aldurazyme hyaluronidase enzyme replacement therapy into the spine, so it'll get into the CNS and into the brain. There was a study out in California. They're not currently enrolling. I think they're doing their data analysis now. But that is being looked at. Then a company called Armagen is doing a phase 1 study of a fusion protein. So what they've done is they've taken hyaluronidase and fused it with an antibody for the human insulin receptor. And what they've shown in animal models is that when you give that intravenously, that insulin receptor, that antibody can bind to the insulin receptor on the blood-brain barrier and take it through. So what they call a Trojan horse kind of approach. So that's very promising. We are doing that phase 1 study here at Emory. We have one patient enrolled. And it is in adults right now. So we think that it will help the adults as well to have, because they do have things like hydrocephalus and cord compression. Maybe it will help address those things. But the big excitement is for the kids. If they were to be able to get enzyme replacement therapy that cross the blood-brain barrier, then could possibly prevent or stabilize their regression. So families are very excited about this. There's also a company called Sangamo. They recently contacted me about a phase 1 study that they are looking to start It is a intravenously delivered zinc finger protein therapeutic for genome editing. So it inserts a correct copy of the gene at the albumin locus in liver cells with the goal of a lifelong production of the enzyme. So that's really all I know about that right now. They just contacted me. So we're working on a contract to then see the protocol. So we'll see what happens with that one, but it could be very exciting as well. All right, so one of the big issues in this condition, why newborn screening is going to be or is so great, is the time to diagnosis. This is from a paper published in 2012. These are patients from the MPS1 registry. So it's run by Genzyme, the makers of Aldurazyme. So this is data about, over time, are we getting better with diagnosis? And essentially what they found was no. So you can see for the Hurler patients, if you look at 2003, the time to diagnosis, so they have symptoms around 0.5 years of age, I guess 6 months, and then diagnosis is occurring about 3 months later. So that, again, is before 2003. You go beyond that. It goes from 0.9 to 0.8 to 0.9. So by 2009 here, it's really no better as far as the diagnosis goes. And similarly, for Hurler, Shea, and Shea, you can see that the time to diagnosis, 4.1 to 3.7 to 3.8, and similarly for Shea syndrome. So that is a problem. Haven't gotten, what we need is to get these kids on treatment early as possible, and they have had too much of a lag between their symptom onset and their diagnosis. This is just another paper that has a little bit more updated data, 2014. And this, so what I showed you before was the all the patients in the registry worldwide, and for this they teased out North America. So a little bit more data, a couple of years later, so it's doing so specifically looking at North America. So this data is from 2003 to 2013, 343 patients. And for Hurler syndrome, the time of diagnosis really has not improved still. So in North America, we're still having the same problem. All right, so then finally to newborn screening for MPS type 1. There are a few states that are already doing this, New York, Missouri, Illinois, Washington State. And as Ronnie mentioned earlier, this condition was, because of the need for early detection and treatment, the Secretary's Advisory Committee did recommend MPS1 be added to the RESP. So what have some of the centers been seeing? Just to show you this paper from Missouri, their 6-month data. They are doing more than just MPS1, as you can see here. So I just wanted to show this to give you an idea of what they've been seeing. We've had 32 patients who screened positive, 1 with confirmed disorder. It did say the severe phenotype in the paper, so a Hurler syndrome. And they have 2 that have the condition, but they're not sure what the onset's going to be. And I'll talk about that more in a minute, too. We got that good old pseudodeficiency. So we have 7 patients with that. Picked up a couple carriers, false positive results. But I mainly wanted to show the confirmed disorder and the number of pseudodeficiency, which is higher than what they expected to see. Then at the World meeting back in March, the World Symposium in San Diego, Barbara Burton presented some of the data from Illinois. And so at that time, about 60,000 newborns were screened, 48 positives. They found 1 case of severe MPS1 and 5 pseudodeficiencies. And then you can see that some were normal in follow-up testing and some were pending at the time of this. But again, they were surprised at the number of pseudodeficiencies that they were seeing. And approximately, if you look at the numbers, it's about 1 in every 10,000 newborns may have MPS1 pseudodeficiency, or alpha L iduronidase pseudodeficiency, I should say. So back in February, this is a letter about how they did approve this to be added to the RUSP. Just wanted to show that letter. Okay, so on to what we're doing in Georgia. We are going to do, starting next month, an NIH-funded pilot program to screen 60,000 newborns for MPS type 1, crunching the birth numbers with the state of Georgia. We're expecting 2 or 3 cases a year. And they're doing the enzyme activity on dried blood spot, using that artificial substrate that we talked about before. So this is an overview of the approach for Georgia. Just wanted to point out, so we're about to begin screening. So for patients that have low alpha L iduronidase enzyme activity, those are going to be sent for follow-up, reported out to the pediatrician, repeat recommended, and then if there's a normal repeat, no further follow-up. If it does continue to be abnormal, then diagnostic testing is recommended. So what are we talking about there? Okay, so diagnostic testing performed. So on repeat enzyme, you might find that there's a pseudodeficiency, well, if it's consistent. If you do molecular testing, you might find those alleles that are common, seem to be common in the African American population. Those are referred to short-term follow-up. Normal results, not concerned, case closed. Then abnormal results, at that point, that's when they come in and see us. And if the molecular testing hasn't been done at that point, of course, we would do it at that point in time. Give the child a good clinical evaluation. We are talking about newborns. So there's not a lot that's obvious for MPS 1 at birth. And then talk about the treatment to the family. And then results reported to the follow-up program. Is that still accurate, Angela? Okay.
The one we are making a small change where we're going to be evaluating screening results using the Region 4 tools and use that to report out cases that are more likely to be real versus false positives.
Okay. All right. Okay, so you have a kid, you diagnose on newborn screening with MPS type 1. Now what do you do? So who are you going to send for transplant versus enzyme replacement therapy? Again, these infants appear normal. Are they going to have cognitive regression? Sometimes we don't know. So just to talk a little bit more about the testing, I touched on earlier for enzyme analysis. That's really not useful as far as distinguishing severe versus attenuated. There's a lot of overlap there. Most patients with the severe form have very little to no enzyme activity. It is possible that a patient with attenuated MPS 1 could also have no activity. And there was a paper that reported that 0.13% of normal activity may be enough to protect the CNS and give you that attenuated form. So you really can't tell anything from the enzyme as far as determining which type, severe versus attenuated. For urinary GAG analysis, again, the level of the GAGs, there's no clear distinguishment between severe versus attenuated there. Quantitative and qualitative analysis I talked about before, very important. I know some labs only do the quantitative. Our lab is not one of them. They do both. But with quantitative, it is possible for an MPS 1 patient to have normal GAGs. So if you're only getting the level and you see a normal GAG level, that could still be a patient with MPS 1. So the qualitative is very important. Also things that can affect urinary GAGs, sample dilution, if you have a kid in clinic and you're really trying to get a urine sample, giving the kid lots of water, juice, whatever. It has happened before where we've had to repeat a test because the urine was too dilute to do the analysis. Okay, so then on to molecular. So it's pretty good as far as doing gene sequencing. It identifies the pathogenic variants in about 95% of patients. Severe patients usually have severe pathogenic variants, nonsense mutations. These are the two I mentioned earlier for the example I showed that are most common in Hurler syndrome patients, severe patients. And attenuated MPS patients usually have one severe mutation and then one mutation that allows them to produce some enzyme activity. So really the bottom line as far as is this severe or is this attenuated is the molecular analysis is extremely important. And you really need two clear pathogenic variants. And they need to be variants that you have some information about as far as knowing if it's going to be severe or if it's going to be attenuated. So for most patients, because the sequencing does pick up 95% of mutations, and a lot of mutations are seen in more than one person. There are some common mutations, but a lot of them are independent to a family. So most of the time, I think we'll know what to do with these patients from a molecular standpoint, but every now and again we might have one where we're not sure what to do with them. Okay, so for our severe patients, we're going to refer them immediately to transplant. And then for attenuated MPS1 patients, we're going to refer them immediately for enzyme replacement therapy. The earlier you treat, the better the outcome, whether it's transplant or enzyme replacement therapy. We've really seen that from sibling studies that have been published where you've got one child affected, next child comes along, to test that child shortly after birth. They have the condition, they're started on enzyme, and they have a remarkably different course than their sibling. We had two brothers in which one had very severe systemic symptoms. He had a trach, extremely coarse, classically coarse, of a shorter stature. We knew to test his little brother, got him started on enzyme, I think by about 2 years of age, which you could say was probably a little bit late. But he is now 10 years old, is just now getting some coarse facial features, before had none, is taller than his brother, and is just overall doing a lot better than his brother. Forgot to mention the severe brother also had early in life had to have a valve replacement, and none of that was seen in the younger sibling. So it does show that the earlier you treat, the better the outcome. So you want to catch them as early as possible. So if it's still uncertain, if you've done all your testing and you're not sure if it's severe versus attenuated, I think we're still working on the exact plan for those patients. It's likely going to be going ahead and starting enzyme replacement therapy as soon as you can get them on, and then monitor them really closely for any signs of developmental regression or any cognitive involvement. That could be neurodevelopmental assessments every 3 months. We're still talking about that part. All right, so I just wanted to end with a case example just to kind of illustrate some of the points. So this is a patient whose enzyme testing came back at not detected. The GAG testing was a little bit elevated. Dermatan heparin sulfate were seen. And in the molecular testing, one mutation was found, one pathogenic severe mutation associated with severe or Hurler syndrome, and a second mutation was not found. So you've got this baby in front of you, what do you do? You might look at these results, the no enzyme activity, the severe mutation. You might think, okay, this could be severe, this could be Hurler syndrome. But it's actually our 40-year-old patient who has attenuated MPS1 or Shea syndrome. So we just can't find her second mutation. But obviously she is making some enzyme, even though in that one assay it wasn't detected, because she's 40, graduated college, definitely not of a severe phenotype. So I think this highlights the need to really have clear molecular results before you decide what to do with the patient. So how did she present? So she, looking back on her life, you can see the MPS way back in early childhood, but how she ended up with her diagnosis was because of her corneas. So she had cloudy corneas. She was seen by, she says, probably 6 or 7 different ophthalmologists who would tell her that she had a corneal dystrophy or that there was something going on with her corneas. They were hazy. But finally, I think the 8th ophthalmologist said, I think this could be mucopolysaccharidosis. And then she got tested, and voila, she has it. She was 38. Yeah, 38 years old, so she's just been on treatment for a couple years. So, but looking back at her history in early childhood, she's got those finger contractures. She was diagnosed with a Madelung deformity, which can be seen in patients with MPS1, but no one really put it all together until she was 38 and at the ophthalmologist. And that, my summary about newborn screening. So it will be difficult sometimes, hopefully rarely, to predict the phenotype for these patients when we pick them up on newborn screening. So there is that uncertainty. If you have a kid, you know the kid has MPS type 1, but you can't tell the parents if they're going to be severe versus attenuated. That's obviously going to create a lot of anxiety and stress for that family. They'll probably be watching their kid like a hawk for any sign of regression. So you can see how that would be very stressful. And then for children for parents of children with a pseudodeficiency, we have seen a few of these kids in our clinic here who were referred for things like developmental delay, seizures, and just as part of their workup, just happened to have a lysosomal enzyme panel done, and bam, that's how they were found to have, deficient alpha-L iduronidase enzyme activity, normal urine gags, and molecular found these alleles that seem to be common in the African American population. But the point is, once they get that label in their chart, get that diagnosis of MPS1, it is really hard to take that away. So for those pseudodeficiency patients that we saw back in clinic, we would tell them, it took a couple years in a row of telling them, this does not explain your child's symptoms. The gags are normal. We think this is a pseudodeficiency. And also, for these children that I'm talking about, they were having problems. So we didn't want the other physicians who saw these children to stop looking for what could be the cause. That was our fear as well. And for pseudodeficiency, again, since we don't have good published data about these alleles that can be referenced, what we might end up doing with them is saying this is pseudodeficiency, here's information about MPS1, if you're ever worried about your kid, call us, kind of thing, because we can't really stamp pseudodeficiency without good literature to reference for that. So there you have more parents that might be hypervigilant, very concerned about their children and kind of watching everything. So children with severe MPS1, if we can get them this early, get them transplanted by 3 or 4 months of age, hopefully we'll be able to prevent that cognitive regression for them. Definitely newborn screening for MPS1 is going to allow patients to get access to care as early as possible, which is great because the earlier you treat, the better the outcome. And the early access provided by newborn screening is going to be very life-changing for these families. Many of our patients with attenuated MPS weren't started on treatment until age 7 or even later. So it'll be great to be able to pick those kids up.
I was interested in why, like, the diagnosis age, there's such a huge gap between the diagnosis age and the treatment age.
Right. Part of that was probably between diagnosis and treatment. Probably providers not being aware of treatments, maybe a lag time between, having a kid with MPS1. A lot of these physicians have never seen a kid with MPS1 before and trying to figure out what to do with that child, how to refer, how to treat.
The first slide, it was a lot larger because it wasn't available yet.
Oh, because the treatment wasn't.
Where there was a big jump between like age 4 and like 6 years. That was just because they had been diagnosed and then the treatment came available, so there was a lag.
Right, so the pre-2003 kids, yeah.
Is there another company which is making the MPS1? Isn't BioMarin? No?
So yeah,
They started it.
right. They started it and they licensed it to Genzyme. So Genzyme now produces and distributes Aldurazyme.
They partnered with them in the clinical trials to do it, and then I think ultimately Genzyme must have bought it off of them, but they probably got a bunch of money.
It's only one company.
Yes, now it's just one. Yeah, yeah.
Yeah.
Can you comment on how in Georgia are you collaborating with the HSCT team here, or will they be going in the region outside our state?
So that's a good question. So for the transplant team, we do have a collaboration now with Children's Healthcare of Atlanta. A few years ago, a doctor started in that group who came from a center that did have a lot of experience in metabolic transplants, such as MPS1. So she's now at SHOA. Some of it will depend on insurance. So a lot of these kids have Georgia Medicaid. If you have Georgia Medicaid and there's an in-state option, such as Children's Healthcare, that's where you're going to go. If you have commercial insurance, then you have the option to go to SHOA, but you could also go to Minnesota or Duke or another center. But we do have a good collaboration going now with the transplant team. And they've transplanted, I think they've just done one child with MPS type 1 with Hurler syndrome, severe MPS 1. And he's done quite well. So we are happy with our relationship with SHOA.
Stephanie, I was going to ask the cost of the enzyme, and you mentioned about the insurance coverage. Do most of the commercial insurance companies pay for it? And is it's costly, I would imagine?
So for the enzyme, do you know how much the enzyme is, Simke? As far as cost? Okay. I know at Greenwood Genetics in South Carolina, I think for one enzyme, it's about $200.
You mean the testing?
Yes.
No, I'm talking replacement therapy.
I'm
talking replacement therapy.
Oh,
sorry.
that's a different story entirely. Yep, sorry, misunderstood. So yes, for the enzyme replacement therapy, it is very expensive. If you look at the top 10 most expensive drugs on the market, enzyme replacement therapies are most of them.
So for adults, probably like $250,000. For the small,
Right.
it's weight based. So for your newborns, it's not going to
weight-based.
be expensive, relatively speaking. Yes, per treat. Oh, per year?
Right.
No, per year.
Yeah,
The dose, depending on the dose, right? Yeah.
every single week for the rest of their lives. So yes, about $200,000 a year is what we're estimating.
And then does commercial insurance cover?
They will. And Genzyme, they have a copay assistance program too. So if we have patients that will have, copays that they, can't afford or whatever, that program can cover the cost of that for them. So really, we are able to get all of our patients on treatment and covered by insurance. Medicaid does.
Programs, or have we thought about that at this point?
Angela, newborn screening guru.
So we are doing this pilot project through the NIH. So we have some special funding while we're doing that pilot project. The good news in Georgia is that all the diagnostic testing we need is done at EGL, which does accept Medicaid. So it's a good story for Georgia. We did, in anticipation of bizarre extraneous situations where children are not covered for some reason, which really almost never happens. But if for some reason they were not covered, we did request funding from the NIH to make sure we could pay for that diagnostic testing. My hope is we never have to use that because really children need insurance.
If it's an undocumented child, would that be like an example? Like a child who's here, undocumented, they're not a.
So for the newborn screening program, that's very rare that would come up because even if children are born here to undocumented parents, they are American citizens, and so they qualify for Medicaid. And so really, via newborn screening, it's incredibly rare that we have insurance coverage issues.
So there's an older sibling, like, because you might find other kids if you find this one.
You know, the other thing, the adoption is becoming more frequent in at least metabolic world we are seeing when the patients are adopted to do the newborn screening at age 1 or 2. And so we have had 7 or 8 metabolic patients in the last couple of years.
If there's anyone listening on WebEx, do you have any questions or comments for Stephanie or the group here?
Oh. Yeah.
So what you mentioned that like none of the treatments really impact the skeletal issues. Why is that?
Well, because there's not a lot of blood flow to those areas, so the damage is already done. Well, Dr. Wilcox, he's explained it in that you're not catching them early enough to really make any kind of impact on what the bones are going to do. I guess we'll find out. If we can get kids started at 1 or 2 months of age, then we can find out more about that. I don't think there's enough data on kids who are that young. But essentially what Dr. Wilcox has explained to me is that, the damage is already done to the bones, even as in an infant period.
So it's the damage that's been done. But if you have the transplant and they engraft and they start generating the enzyme on their own, then you would think you wouldn't have further damage to the bones, right, or not? I mean,
well, I think because the blood flow is so poor, and with however bones develop, I think it's kind of too late for the bones, if you will.
Just one more request for WebEx users. Does anyone have any questions? We had your audio off a second ago.
Oh, I can hear it.
Yes, we can hear you fine. Thank you.
Oh, okay. Yeah, this is George Casey, from Tennessee. I was wondering if the fluorescent substrate before immune produces more pseudodeficiencies than the substrate that we use for mass spectrometry.
Unfortunately, we don't know the answer to that one. That is a good question.
I don't know the nature of the linkage there that's being, attacked by the enzyme. If it's, kind of more persistent, but I know, Illinois data is from mass spec, and they had pseudodeficiencies too.
In my conversations with our lab director, I'm certainly far from being a lab person, but I think she's actually planning on doing mass spec. Now we've had a few changes in plans, but I know she's anticipating us getting pseudodeficiencies despite us using mass spec.
Well, maybe on the call this afternoon for the MPS1 call.
She will.
Okay. All right. Thank you. That's very good.
Any other questions or comments from our WebEx users?
Okay, well, I also hope we can capture this data for long-term follow-up, which we are advocating for all the diseases as we move as an activity for the newborn screening, not just stop at screening and diagnosing the patients, and really create registries. And NBS TRN is one, and we will probably do a series on that also in the future. So since you're just starting, I thought I'll throw the plug in for that. And with that, I thank you all for coming, and enjoy the pizza. And
Thank you.